Good afternoon, everyone, and welcome to the second webinar in our Catch Up with Cancer Movement series, with today's session focusing on the cancer treatment journey. I'm joined by three fantastic speakers who I'll be introducing shortly, but first for a little bit of housekeeping. So we would encourage anyone to be submitting questions throughout the webinar, and we will answer these questions at the end of the session. There should be a Q&A function on your screen. When submitting the questions, please include your name and email address, so if we don't get to these, we can respond directly to you after the event. We are also recording this webinar, and a copy of the slides will be sent out afterwards. Lastly, towards the end of the session, we'll be posting a feedback link, and we'd be really grateful if you could take a couple of minutes just to let us know your feedback on today's session. So to introduce our speakers, so today I am joined by Malcolm Wilson, who's a consultant colorectal surgeon, Richard Scott, who's a client of mine, and Sarah Weston, who is Head of Services and Support for Bowel Cancer UK. Our first speaker is Malcolm. He's been a consultant colorectal and pelvic oncological surgeon at the Christie Hospital in Manchester since April 2000, having previously had consultant posts at Macclesfield, Stepping Hill, and University Hospital South Manchester. He was Director of Surgery at the Christie between 2006 and 2014. He's currently lead clinician for colorectal surgery, joint lead of the peritoneal tumour service, and a member of the pelvic tumour team. He's also an honorary senior lecturer at the School of Medicine, University of Manchester, and a consultant appointment assessor at the Royal College of Surgeons. Malcolm's also a medico-legal expert and acts as an expert witness in medico-legal cases. Welcome, Malcolm.
Thank you very much, Rebecca, and thank you to all that's organised this fantastic day. I've been asked to speak about advances in colorectal cancer treatment in the UK. And actually, there are lots of things to be positive about. Now, hopefully, you will be able to see my slides fairly shortly. So, Donna, if you could do the honours, please, and put those on for us. Okay, so I'm hoping you can see those slides now. Let me just click on that so I can see them as well. So bowel cancer, it remains a very common problem. And as you can see, the statistics can be quite scary. It remains around about the third most common cause of cancer death in the UK. And that pretty much reflects the whole of the Western world experience. In the UK, about 1 in 20 women and 1 in 17 men will be diagnosed with bowel cancer in their lifetime. And that's for somebody who's my age, born in 1961. So those of you who can do the maths quick enough can work out how old I am. The amount of new cases that occur within the UK is around about 43,000 new cases a year. Now, the interesting thing is about bowel cancer is that it is eminently treatable. And as I'm sure a lot of you are aware, there is a precancerous stage for bowel cancer where you get these benign polyps forming within the bowel. And if you can identify it at that stage, you can basically remove them and remove the risk of the bowel cancer. Now, you can see from the pie chart on the screen that there are a variety of risk factors, and a lot of which are entirely avoidable. And this pie chart has changed over the period of time I've been a consultant over the last 20 odd years. And certainly things like the effect of poor diet, obesity, and alcohol have become more prevalent in terms of causation with regards to bowel cancer. There's recently been a lot of data that's come out of the US, which you may have seen highlighted in the news recently, which has suggested that although there's an overall trend downwards for colorectal cancer in all ages, actually in young people, the incidence is going up. And that is certainly something that we see as clinicians. There are more and more people between the ages of 25 and 50 that have this disease. And certainly the data would suggest that over the last 20 years, well, 1998 to 2018, the incidence in people of that age group, 25 to 50, has gone from 4 per 100,000 to 6 per 100,000 patients. And it would appear that the large driver behind that is poor diet, obesity, lack of exercise. Next slide, please. The fact remains, however, that, as I've said already, it is essentially largely a preventable disease. And as Max Verstappen would tell you, the current Formula One world champion, the quicker you can get somewhere, the better you do. And that is certainly the case with regards to bowel cancer. Next slide, please. So what I want to talk about, if I may, today is just to split it into 3 areas where I think there have been some really big improvements. And certainly there's a lot to be optimistic about. The first area I'm going to talk about is screening. Then I'm going to go into some sort of slightly more esoteric things about surgical treatments and where we've improved there. And then I'm going to end up talking about what we call targeted therapies, which is really exciting and shows a huge amount of promise. So let's talk about screening to begin with. Anybody who's in the age of 60 onwards will be aware of the fact that this country has been running a national bowel cancer screening service for really quite some time now. Interestingly, you can see that there are some discrepancies between the home countries. And if you're going to opt for early screening, the best place to go is Scotland, in spite of the fact that Nicola Sturgeon's been on the news just recently. And was on at lunchtime, actually, making a bit of a fool of herself, but there you have it. But Scotland are very progressive as far as this is concerned, and probably more so than the other home countries. One of the big changes that we've undergone within the last 5 years is that the type of testing that's been introduced has changed. We used to use something called fecal occult blood testing, which was essentially looking for blood degradation products in people's stools. And this was superseded in around about 2016 to 2018 with what's called FIT. And everybody calls it FIT testing, but it's not. It's FIT because it stands for fecal immunohistochemistry test. So you can't have a FIT test, as it were. And this is a much more accurate test. And essentially what it's doing is it's using immunohistochemical techniques to again look for blood in the stool. Now, in England, it's variable as to where you live, actually, as to when you start to be invited to undertake these tests, which you do every 2 years. It used to be 60 to 74, but they are dropping that lower age group down systematically. And I think in some parts of the country now, we're looking at 54 being the entrance date, which is done by postcode. As you can see, in Scotland, it's 50 to 74. In Wales, 51 to 74. Next slide, please. The big advantage of using FIT over the traditional fecal occult blood testing is that it's much easier to use. It's a single test as opposed to having 2 or 3 separate tests that you have to send back. And it's less affected by things such as diet, which could erroneously make the tests go positive with the old school thing. Now, where it also differs is that fecal occult blood testing had to be read manually, and it was either on or off. It was either positive or negative. FIT, however, can be done in a far more objective manner. It's a machine that does it, and essentially it's done on a scale. And so there are 2 settings, if you like, for the amount of blood that you look for in the sample. In the screening situation, where you don't want to necessarily pick up loads and loads of falsely positive subjects, in other words, people who've got a positive test, but they don't have any disease, but you do want to pick up a reasonable number of cancers, that is different to somebody who presents with symptoms and you're trying to work out whether or not they could have a bowel cancer. So essentially you set the threshold of the test depending upon which setting you're looking in. So for patients who just go into their GP saying, I've noticed a change in my bowel habit, I'm not sure whether I've had any bleeding, but they're not within the screening age, then the test is set very low at 20 micrograms per gram of stool. And that makes it extremely accurate. It'll detect about 83% of patients who have cancer. And indeed, studies have shown that if you have a negative test in that situation, the GP can't find anything when they examine you and you've got normal bloods, your actual risk of having a bowel cancer in that situation is less than 0.1%. In the screening situation, however, what they do is they set the threshold higher at 120 micrograms. And it varies again between which country you live in as to which the exact figure is that they use. But the advantage of that is it's a good compromise between what you call sensitivity, in other words, the risk of detecting people who, or rather deeming them not to have cancer when they do, as opposed to specificity, which is somebody who has a positive test who doesn't have the disease. And so it's a balancing act. Next slide, please. And what you can see is that using these things, using these screening tests effectively, both reduces the incidence of the disease because you pick people up before they get the bowel cancer, but you also reduce mortality. And the projected reductions in mortality is in the order of 20+%. So it's a very significant event. And these are the levels that the home countries have set for their screening population. So in Scotland, they set it really quite low at 80 micrograms. England's 120 and Wales is 150. And it will yet to be seen as to how that reflects going forwards in terms of the patient outcome between the screened population between the countries. Next slide, please. So in addition to that, the GPs, primary carers, have been given advice from a combination of sources as to when you should refer somebody urgently because you think they may have bowel cancer. And before 2015, it was really quite straightforward. It was just those 6 criteria that you see on the screen. Things like persistent bleeding, change in bowel habit, a palpable lump, either on abdominal examination or digital rectal examination, or the presence of anemia, particularly in men. Then, next slide, please. Then NICE got hold of this, and they issued a set of guidance called the NG12 two-week referral guidance, and that was established from June 2015. And you can see on the slide, it all becomes a little bit more subtle, a bit more nuanced. It remained really the sort of industry standard as to when you should refer somebody for what you call a two-week wait referral. And that's when you suspect that somebody has bowel cancer, and the institution who picks them up is then duty bound to come up with a diagnosis and a management plan within 31 days of the referral. And if they have got cancer, to give them their first treatment within 62 days. And people were just about settling in and getting the hang of all of this when, lo and behold, this last October, next slide, please, they've changed it again. And again, there's this emphasis on using FIT and who you should refer. So in this situation, rather than using the screening level of detection, you use the much lower, the much more sensitive level of detection. And NICE, just to be confusing, have suggested that that should be 10 micrograms per gram. And basically what they're saying is that the GPs, if they see somebody in their practice who they suspect might have a bowel cancer because of a variety of symptoms or signs such as are laid out here, that they should do a FIT. And if the FIT is above 10 micrograms, then they should refer them. And when one's looking at whether or not somebody's been mistreated, they've had a delayed referral, the lawyers are very keen on the wording of these this advice. And you'll notice that it's caged slightly cautiously by saying that you should offer adults a FIT and refer if they're the FIT is at least 10 micrograms. And that has changed from the previous NICE guidance, where there were only very small numbers of ones where the referral was mandated. It was the words we used were consider referral. And so I think this has probably clarified it a bit in terms of making sure that people are referred when they should be. The only group where you don't really have to consider doing a FIT these days is if the GP finds somebody who's got a clear lump that they can feel in their abdomen, or on digital rectal examination. And hopefully we are now in an age where the GPs realize that if they don't put their finger in it, they'll put their foot in it. And most patients do actually now have digital rectal examinations when they're required. It's an extremely important examination to be done. Next slide, please. So you might say, well, where's the evidence that having a bit of a delay actually makes any difference to the final outcome? Are you not just warning patients of something that is inevitable that's going to get them in the end in any case? Well, there could be potentially an element of that, but actually there is some quite good data that goes back now 10 years that shows that actually the longer you wait, the poorer your outcome is. And that's pretty much across the board in terms of gender, race, origin, and indeed the stage of presentation. So it is important to be a Max Verstappen and not to be somebody who's at the back of the grid with an engine that's expiring before you even get to the end of the first lap. Next slide, please. So that's all kind of before the patient gets to hospital. And the emphasis is very much on early diagnosis, making sure that people are aware and getting them to treatment. Now, where has treatment advanced in the last few years? I think it's fair to say that there have been some very serious improvements in terms of certainly how surgery is performed. Everybody's aware of the sort of sexy bits of kit that are now available, the robotics that we use routinely, the fact that a lot of surgery is now done using what we call minimal access techniques. But there are more subtle changes, if you like, which have had a much bigger impact in actual fact. There's a gentleman called Bill Heald, who was a consultant at Basingstoke, and he popularized the approach as to how you remove rectal tumors in particular, using something called a total mesorectal excision. And all he did really was apply functional anatomy to the removal of tumors. And that had a huge impact on people's survivability with rectal cancer. And it kind of gets forgotten in the sort of, in the media when everybody gets so excited about another piece of equipment that sits there costing a fortune. I was fortunate when I was clinical director at the Christie to be involved in the introduction of our first robot back in 2007. We're now on a third generation robot, and we have 2 of them. They are extremely effective if used correctly. But at the end of the day, they are just still a tool. It's a question of making sure that you still do the operation properly. Now, what are the benefits of using these minimal access techniques? Well, in the short term, there are some very significant benefits, providing the patient can be done without complication. The amount of pain that is suffered, the cosmetic changes, the early mobility, these are all massive benefits. And from a health economics perspective, patients spend a lot less time in hospital, and those of working age get back to work quicker, so they start paying their taxes again. So, you know, as a health economist, definitely, in spite of the fact that a robot would probably cost now in the order of about £1 million to buy, and then probably has yearly running costs, irrespective of whether you use it or not, in the order of about £100,000 to £200,000. Nonetheless, they can actually save money in the long term. Interestingly now, though, because they've been around for 20 odd years, these techniques have not actually shown much in the way of difference in terms of long-term benefit when compared to the traditional open surgery. And indeed, there's an increasing amount of data. A lot of it's coming out of Japan, where they're very technologically advanced, where there are warning signals coming out that if you're dealing with patients who have very high BMIs, body mass indexes, they've got advanced disease at presentation, and the tumor itself is quite big, the advantages of these minimal access techniques is probably minimal. And because I'm something of a dinosaur, and I don't tend to do a lot of minimal access surgery, because the type of surgery that I do is basically encapsulated in that line of patients with high BMI, advanced disease, and large tumor size. We look at using these minimal access techniques all the time, but in actual fact, a lot of it is not applicable in my practice. So, you know, in terms of evolution of man, on the bottom of that screen, I'm probably somewhere around the middle guy with the club, actually, rather than Homo erectus with his spear next door to him. Next slide, please. We can, however, use a lot of very sexy technology, which is actually extraordinarily helpful. And one of the projects that we're running at the Christie at the moment in Manchester is the use of 3D printing, or at least 3D realization of images. And so essentially what this allows you to do is that you take the data from a CT scan, and then some very snazzy software will then basically form this 3D image, where you can rotate it, look at it at different angles. You can take away certain components and add in certain components. And if you have a 3D printer attached to this, you can actually then physically create an object. We use it in terms of being able to inform patients as to what they're looking at. We use it less so for planning of procedures, but certainly in some areas of surgery, in some areas of oncological surgery, particularly when the orthopedic surgeons, the spinal surgeons are involved, they do actually use this as a way of either creating implants that they can put in that fit, or indeed in terms of planning surgery. But at the moment, it's still very much at a research stage for us. Next slide, please. But using this kind of information allows you to do surgery far more accurately. And one of the things that, one of the areas, if you like, which has been a big expansion is this so-called navigation surgery. In other words, using essentially artificial intelligence to direct the surgeon to the right area. And I'll give you a couple of examples. One is the use of GPS positioning. So it's using exactly the same technology as the GPS system in your car, whereby it knows where you are, it knows where something else is, and it can direct you to that. And again, in the use of spinal surgery, neurosurgery, orthopedics, this use of GPS positioning and connecting what the scans are showing you to what the patient has to allow you to direct the surgery very accurately is something that is now being used in increasing numbers. And certainly from my perspective as a pelvic oncologist, where this becomes very useful is where you have say a rectal cancer that, due to its size and its malignancy, its aggressiveness, it's gone into the bony structures. And you can use this kind of technology then to be very precise about where you remove which bits of bone, essentially, the advantage of which you remove the diseased tissue, but you leave behind the good stuff. And the aim being is that you reduce the amount of damage that you do in the process. So it's still incredibly cumbersome, it's extremely expensive, and requires really quite a lot of dedicated machinery in order to do it. But like all these things, with time, it will become more commonplace, it will become cheaper, it'll become better. And so, you know, a lot to be looking forward to going forwards. Next slide, please. And the other area that I'll just bring your attention to is the use of, as well as using scans to identify where you want to go, there are an increasing number of techniques now where you can actually inject patients with essentially a tracer substance, which you can then see at the time of surgery. And we've got 4 images there. I'm sorry to be a little bit technical about this. A, B, C, D. So the top 2 images, A and C, that's how they look like in real life. And the 2 bottom images is under what we call a near infrared camera system. So it's essentially you're putting it in out of the normal visible range of light. But the cameras then pick up this fluorescent dye. And it can be very helpful for a couple of reasons. One is that it can allow you to identify, say, for instance, you've got a section of bowel and you want to make sure that the blood supply to that bowel, A, you can identify it, and C, and B, that you can see where the blood supply is essentially stopped. So one of the big problems that we have in terms of bowel surgery is when you take a section of bowel out and you're left with 2 cut ends, which you then aim to join together, both of those need to have a good blood supply, or otherwise the joint just falls apart. And it's one of the sort of age-old things in surgery that you've got to make sure that you've got adequate blood supply to both ends, because otherwise the joints don't work. So if you look at the image in your bottom right-hand corner, the one that's labeled D, you can see where the arrows are. To the left of where the arrows are, it looks green. And that's where the blood supply is. That's where the dye is getting. But to the right of that, it just looks gray. And the reason being is that it hasn't got any blood going to it. Now, when you compare that to what the real live image looks like, it actually looks the same. You can't tell. So we can use them, therefore, to identify areas of circulation. The other use of this is that you can use dyes that are specifically taken up by tumor. And we've been doing this for ages using a technique in radiology called PET-CT imaging, positron emission tomography CT scanning. And there you give patients essentially a radioactive isotope of a form of fuel, and that fuel gets preferentially taken up by tumor cells. And you can then pick it up on the imaging. And it's now refined to such a point where you can actually do it in real time without having to use a PET scanner or a CT scanner. You can do it by using these optical techniques. Still very much in the developmental phase, but going forwards, again, it's a big area of development. And this whole process of navigation surgery is a very exciting one. And it's one that hopefully will direct surgery to be far more accurate and far less damaging to how surgery has been in the past. Next slide, please. Now, I'm in a danger now of getting a little bit off piece, but the one thing I will just say, sorry, about surgery is that one thing that has happened is that there's been an increased specialization of specialist units. And my own unit is a case in point, really. When I started out at the Christie, which itself is a tertiary cancer centre, there were 2 of us doing bowel cancer surgery, and we're now 9. We've gone from 2 theatres up to 8. And we've, if anything, our focus has narrowed down as to the sort of surgery that we do. So we're one of the 2 specialist units that deal with a particular type of cancer, appendiceal cancers. There's only 2 of us in the country that deal with that. And we also specialize in the advanced malignancies in the pelvis. Now, by specializing all of that into one group means that you have a tremendous increase in terms of experience. There's cross-fertilization with other units, so you get experience of dealing with difficult areas. You have the research that goes behind it. So the increased specialization of surgical units is something that has definitely driven improvement in patients who have things that are not straightforward. And that in itself has a big impact. One of the diseases that we treat, if you weren't to have what we did to people, this so-called cytoreductive surgery with heated intraperitoneal chemotherapy, you'd be looking at something that would kill patients within, to a large extent, 24 to 36 months. We now have patients who are 10 years plus survivors and essentially will become long-term survivors. So it definitely has a positive real benefit. Next slide, please. So quickly then, I'm just going to go through some other areas that are definitely outside my area of expertise, but I'm just going to highlight them to you because they're very exciting areas in terms of managing bowel cancer. In the traditional sense, chemotherapy used to be basically directed, it was essentially a poison that was directed towards the tumor cell and would kill the tumor cell. The trouble is it would kill quite a lot of normal cells as well, hence the reason why it could be really pretty toxic. But more and more targeted therapies are coming in, whereby you use the patient's own immune systems and you attack its own tumor profile, and it's very individualized. And one of the areas that is particularly exciting in rectal cancer is this colorectal cancer as well, colon and rectum, is this use of what we call immunotherapy. And essentially what you're doing there is you're manipulating the patient's own immune system to attack the tumor. Next slide, please. And it's only really applicable to certain patients. We all have this ability to repair our own DNA. And certain individuals have this thing called mismatch repair defective genes. And so they're unable to handle the bits of snippets of DNA that get chucked out when it's replicated itself. And that is a marker of some people and their ability to form bowel cancer. Now, if you detect the fact that you have a patient with bowel cancer who is mismatch repair gene defective, they are then potentially suitable for the use of immunotherapy. And essentially what you're doing is you're blocking receptors in the tumor cells so that they are no longer invisible to the patient's immune system. Next slide, please. And one thing that we're seeing more and more, and I have firsthand experience of dealing with these patients who really you would have thought they are never going to get over this. They are never going to be cured of this disease. And if you look at the results on this slide, where it says BSC, that's best supportive care in a patient who has metastatic bowel cancer, so disease everywhere, and they have really quite a short expected life length. By increasing the level of chemotherapy, you can push that out by a matter of a few months. But then comes along patients who are then suitable for immunotherapy treatment. And suddenly you're seeing 50% survivors at time intervals that are way outside where you'd actually expect to see any of them surviving. So it is an extremely exciting area where it is constantly evolving. And we really are beginning to see some very positive results with this. Next slide, please. And then finally, what you can do, again, through understanding what an individual tumor's profile is that you look, again, for various receptors and various markers. We look for things like KRAS and BRAF expression. And you can use certain types of monoclonal antibodies. So these, again, generate an antibody response by locking onto a receptor, which then drives tumor growth. And by putting in these drugs, you're stopping the tumor growth factor, if you like, the thing that's produced by the tumor that makes things grow. You're blocking its effect. And there's a number of these different drugs now that are available. And again, all showing really exciting promise. And next slide, please. So in conclusion then, bowel cancer remains a problem. There's no doubt about it. And potentially it's becoming more of a problem for young people. However, there really is a light at the end of the tunnel, and it's not a train coming towards you. With better screening, earlier diagnosis, improved surgical techniques, better collaboration between groups, the use of all the sort of available artificial intelligence, and now the use of these targeted therapies, we are definitely seeing the beginning of a golden age in terms of managing this horrible disease. I'd like to finish there, but I just thank you all for listening.
Thanks, Malcolm. That was really interesting. Our next speaker is Richard Scott. Richard is a client of mine, and he lives in Bristol with his wife and daughters. He was diagnosed with bowel cancer back in 2022 and has been navigating the challenging roller coaster that cancer brings. And Richard's going to tell us a little bit about that journey today. Welcome, Richard.
It happens to all of us. It's something I fully expected would happen to me somewhere down the line, and I work for a terminal illness charity, so actually that's only strengthened my mindset with that. That was until August the 18th, 2022, and probably from that day, not a day passes by without my mind focusing on that fear of death. And it's not necessarily the death that terrifies me, it's the consequence of what that death would be. And I guess that's an unwanted side effect of being a young person. And it's not often I'm called young anymore, but a young person diagnosed with cancer. So my name is Richard, and I'm just going to go through today some of my roller coaster of a cancer journey and the treatments that I've been through. Next slide, please. So I'm just literally going to talk about the diagnosis, my scans, the chemotherapy side, the surgery, and where I am now and looking forward. Next slide, please. But I just wanted to firstly introduce who I am, really. So I'm 42 years old. So as Malcolm said, I'm under that 50-year-old. So I'm deemed a young person living with cancer. I'm a proud Bristolian, lived here all my life. I've got the most amazing family. So I'm married to Annie, and I've got two children, Erin and Hattie, who are aged 10 and aged 7. I love the outdoors. I'm a really keen runner, so I've always been into my fitness. And we'll get onto my running a little bit later on. But I'm also part of a club that nobody wants to be part of. Next slide, please. So as we embark upon World Cancer Day, I was asked to talk to you about my experiences and specifically my treatment plan. But before I kind of talk about that, I think it's important to state that today is just that. It's my experience, it's my roller coaster, and it's my boat in the cancer ocean. There are over 375,000 cases of cancer every year. Every 2 minutes in the UK, someone else is diagnosed. And as we've already heard, bowel cancer alone has 43,000 cases. Each of those people has their own roller coaster. It's personal to them and it's different to anyone else's. So today is my own personal story, and in no way do I want to take away from anyone else's. I think our one common theme that we all have is that we're all part of that club, as I mentioned, that nobody wants to be part of. Next slide, please. So I'm going to take you back to August the 18th, 2022, and that was a day when I was told that I had cancer. I'd been booked in for a colonoscopy by my GP, and this was because after several years of me reporting blood in my stool, extreme fatigue, an unusual and unnatural need to go to the toilet, which transpired was my tumour pushing onto some sensors within my body. It was suspected IBS due to my age, so I was booked in for my colonoscopy, and I fully expected to come out of that appointment with a diagnosis of IBS, but a relief knowing what was causing all of those issues that I'd been presenting for the previous few years. For those of you that have never had the joys, colonoscopy is a really uncomfortable procedure, but ultimately something that can be a lifesaver when it comes around to people with cancer. I was told just after the examination that they had found something that was irregular, and I need to talk to a colorectal nurse, and that they were going to call my wife Annie, who was waiting, to come into the room with us. Now, you know when you get put into a private room and a separate room and they're waiting for your wife to join you, that you're not going to get told good news. So I knew quite quickly that something wasn't right, but I still wasn't quite prepared for what followed. And hearing those words, excuse me, hearing those words, "You have cancer," really does come like a sledgehammer. For all those fantastic developments around the illness, where half of those diagnosed survive for more than 10 years, there's still a cancer death every 4 minutes. So for me, it was impossible to not let my thoughts go to that worst case scenario, especially when at that stage you don't have the full picture of what's going on, and especially when we live in a land where Google is literally a fingertip away. Ultimately, at that stage, all I knew was I'd been given a ticket for the world's worst roller coaster, but I wasn't sure what that looked like and what it entailed. Next slide, please. One of the worst parts of a cancer roller coaster is the waiting, especially the waiting after the initial diagnosis when you don't have a plan. For me, I knew I had cancer in my bowel. We didn't know to what extent. And that's a really tough place to be mentally. And even now in the bowel cancer communities that I'm part of, it's a really common theme when somebody new is being diagnosed, that you see that real fear that they don't have their plan and they just have that initial information and they're not sure what to do with that. It is really terrifying, and it's really unknown, and your mind naturally wanders to the most horrible places and thinks the most horrible things. There were some MRI and CT scans I had to attend over the first few weeks post-diagnosis, and then there's more waiting for the multidisciplinary team to get together and look through those results and discuss them. Scans themselves are a really lonely place, and that's during, before and after, and scan anxiety in the cancer world is a real thing, and it's something you hear quite often. I still endure this today, and I've had over 10 MRI and CT scans since being diagnosed. The build up to a scan is the fear of what they're going to find. So for me initially, it was has it spread? How big is the tumour? Is it going to confirm my thoughts that I'm going to die? The scan itself is just uncomfortable. MRIs particularly, you go right into a tube, your head is literally touching the ceiling above you, so it's really claustrophobic. And you have 45 minutes of noise, but equally your mind is just thinking worst case scenarios. And in the aftermath, you're back to the wait. You never get your results straight away. And it's that waiting for the team to meet and discuss what they look like. I also had that at this stage had a PET scan, which Malcolm's already mentioned. And for that, I wasn't able to be around my daughters for 24 hours because I was radioactive. They did go into school and tell their teachers that I was green, but I can confirm I definitely wasn't green. It was just radioactiveness. So it's safe to say I've been through a lot of scans, and after those initial scans, I remember quite vividly on a Tuesday afternoon, sat here working, and getting a phone call from the oncology team to ask me to come in and talk about the results, and asking if I could make it in that afternoon and whether Annie would be able to come with me. Again, knowing that quick turnaround, I knew I wasn't going to be getting good news. And just a few hours later, I was told that the scans had shown that my cancer had spread to my liver, and that it was as serious as it could get without them telling me that it was inoperable. I remember leaving that room feeling numb. I was lost. I felt terrified. I knew what stage 4 cancer was, and I knew that it wasn't a good thing when your cancer reaches the lymph nodes and begins to spread around the body. So it took some time for me to take in that news, and I remember it being a few days later when it finally really hit me, and being led in bed and just bursting into tears. And my biggest fear at that stage was Annie, Erin, and Hattie, because I wanted to watch them grow up, and I wanted to see Erin go to big school, which she goes to this September. I wanted to be able to support Annie through those trials and tribulations of 2 teenage girls. And I wanted to see Hattie grow and develop as a young girl. And I was terrified that I was going to miss out on all of those things. And I had no control over that. And that lack of control is really devastating. And I still have never been able to put into words quite how that made me feel at that time. After my PET scan, I was then given my treatment plan. They discovered I had 9 metastases on my liver, and I had a 40mm rectal tumour low down in my rectum. And as it stood at that moment, I would be put on a cycle of chemotherapy, which would initially be 8 cycles. And then I would have surgery on my liver if I was suitable for that surgery. And then I'd have surgery on my bowel, which would lead to me having a permanent stoma based on where the tumour was. Next slide, please. So chemotherapy can do the most amazing things. The progression in its use has been remarkable, but it's still probably one of the darkest moments of my lifetime, and one of the worst parts of my cancer roller coaster. I remember my first session was the October after getting diagnosed. So that was 8 weeks post finding out I had cancer. And in all of those 8 weeks, you're fighting this mental battle where your mind is telling you the tumour is going to be getting bigger. It's telling you the cells are going to be moving to different parts of your body, and it won't just be my liver that's affected. And it's a battle that you can't win. You just can't fight it. So I learned quite quickly I had to try and control that, and to allow myself to have those bad days, because you just have to sometimes switch off. There are many different types of chemo depending on what type of cancer you have. For me, and for quite a lot of bowel cancer, I had Xelox, and it was Xelox that I was placed onto. And that began for me with an infusion on a Monday morning in my local surgery. I was lucky that the hospital had a few satellite clinics, and one of those was a 2-minute walk from my house, which was really helpful for me. And then after the infusion, it was 14 days of taking tablets. So that would be 4 in the morning and 4 in the afternoon. And then I'd get a rest week, and then the process would start again, and I'd go for the same thing over and over. The infusion itself was around about 2.5 hours, attached to a drip with the drugs entering my system. And the longer that session goes on for, the worse you feel. And the more sessions you go through, the worse the side effects and the worse the feelings you have. I remember being really tired. I remember being really drowsy. The longer the drip would go into me, my speech would become more slurry, and your throat would become really dry, and you develop a real funny taste in your mouth as well. Concentration was really difficult. So I'd gone in like my first day at school, and I had books and I had Sudokus. I downloaded some Netflix series. I downloaded drama, in fact, to watch when I was there. But in honesty, all I did was sit there and hold my wife's hand and literally just be there for a few hours, and not really doing anything of any substance. There are many side effects of chemotherapy. Some people are lucky and they get none of them. Other people get all of them. And each type of chemo is a little bit different. For me, the side effects that I went through was extreme fatigue. For about 4 to 5 days after the infusion, I was just totally wiped out. I would spend my time there on the sofa, and I have no energy to do anything, which with 2 young girls is really difficult. I remember really severe arm pain from where the cannula was, and each session I'd have to swap arms because it was just excruciating, the pain within my arms, and that got worse and worse the more sessions I had as well. And my veins became really hard, and it was really freaky when I first noticed it, but just these really hard veins where the drug was obviously constantly going. One of the other parts was, and I can never say this word, but peripheral neuropathy. Basically, the treatment really affects the nerves, so it affects the hands and feet, and they become really numb. They become really tingly, and in the weeks after having the infusion, I really struggled to be able to hold any metal cutlery. I couldn't pick up milk, couldn't really touch anything cold at all. It would just send pain and sharp pains from my body. And even now, I have real issues with my circulation. And there's a picture later on in the slides of my hands from just being at the beach for a day, where they just went blue when it got so cold. The worst part for me, however, was the mental side. I was on a cocktail of drugs, so I had the infusion, I had the tablets, I had steroid tablets, I had anti-sickness tablets, I had several other tablets that I was taking at the same time. And they really caused havoc with my mental side, and they took me to places that I really struggled with. And I've never been able to explain it, but it was like playing tennis with myself inside my head, with my thoughts. And I would spend day upon day just pacing up and down the house, just struggling to deal with that. And my only solace being at the end of the day at bedtime, when I could go to bed and just close my eyes. After the second cycle, you always get the chance after each cycle to talk to the oncology team. And I explained how I was feeling, and I got referred to the psychology team, who were brilliant at helping me put in some processes to cope with that and some coping mechanisms. And they also reviewed my dosages and took away the steroids and the anti-sickness drugs. And from that moment, although it was still a horrible time, the mental side was much easier for me, and it wasn't so challenging. Next slide, please. So I took my last chemo tablet on Boxing Day, and I can't lie, it was a huge relief for me to be finished. I wouldn't wish chemo on my worst enemy, and I can never find the words to say how much that impacted me and how much it changed who I was in terms of my energy, my personality, my confidence. I genuinely hated every minute, and it terrified me that at that stage, in all likelihood, was I would need to go through that again, and I didn't know how I was going to find the strength to do that. The next steps were more CT and MRI scans. The anxiety was even more heightened because if the chemo hadn't worked, then liver surgery potentially could be off the table, and I knew that they couldn't operate on the liver. There was a risk that they wouldn't operate on the primary. So it was really difficult times, but luckily for me, my scan results were really positive. The chemo reduced the rectal tumour, and actually some of the metastases in the liver were actually invisible to the scan, which meant we were in a position to move forward to have some liver surgery, which was brilliant. However, there's one final hurdle to overcome, and that's the fact that when they remove part of your liver, and I was lucky that all of my metastases were on one side of my liver, but when they remove it, they need to leave an amount, which is magic numbers around about 35% for your body to be able to function afterwards. And with me, when they did all of the workings out, if they would have removed all of my area of the liver that was affected, I would have less than that left. So they had to do some magical operation, and in really unscientific terms, they had to do what we call a portal vein embolization, and it's where they essentially superglue one of the veins going into the bad area of the liver, which diverts the blood to the good area of the liver, and in time that good area will grow bigger. And the idea being is after 6 weeks, they'll be able to rescan you, and hopefully your liver, then the good side that will be left, will be big enough to be able to cope with them removing the bad side. Next slide, please. So after another scan 6 weeks later, the really good news for me was my liver had grown, and I was given my surgery date of April the 4th, and that was when I would have open surgery to remove the parts of my liver that were affected. Surgery day has become more and more of a blur the more time's gone on. I remember being there really early. I remember the walk down to the surgery room. I remember having to leave Annie and her. I just remember walking away and how upset she looked. I remember them really struggling to find a vein to put in all of the wires they had to, which is very unlike me. I've during this process been injected and had blood taken so many times, and they never finding a vein difficult. And then I remember waking up. That was 8 hours later, and 50% of my liver had been removed. I was told the operation had been a success, and as far as I could tell, they had removed all of the areas they planned to, and all of them with good margins. So that was really, really great. They also removed my gallbladder, although I never found that out until I had a scan a few months later, and I was asked if I had a gallbladder. But in their defence, they could have told me, but I was very out for the count, I think, when I first came round. I had 5 days in hospital, 2 of those in high dependency, wired up to all sorts of machines, incredibly scary, incredibly drugged up on high painkillers. And then I had 3 nights up on the ward before I was able to go home just in time for Easter. A few things that stick in my mind, and like I said, a lot of that I forget, but I remember walking. They really encourage you, if you want to get home earlier, to get up on your feet and move around. And for someone who's always been really active, and for somebody who's run a few marathons before, not being even able to walk from my bed to the bed the other side of the room without struggling, and I must have walked the corridors of the BRI in Bristol countless times when I was there, but it definitely helped me, and it helped my recovery, and it got me out of the hospital quicker than what I probably would have. The drugs, I remember being on a really high cocktail of drugs. I remember waking up and thinking that the fan in the room was a frog. And I remember really vivid, horrible dreams that I was having due to the strength of the drugs that I was on. And I remember the loneliness of being in hospital and not having the girls around me because they weren't allowed to come and visit me. One of the rules that they had in there. The surgery itself has left a pretty cool scar, as you can see the scar on there. It wasn't stitched at all, so that was all glued. I still now have some uncomfortable feeling around that, primarily because where they cut across my core, they went through all of my nerves. So some of that is just where some of that kind of nerve messaging is coming back. I have no core. I'm doing my best to kind of build that back up. I must admit, I've never had a 6-pack before, and I certainly don't have one now. But that's been a real challenge for me, just trying to kind of build that strength back up and kind of get over that kind of really intense surgery. Next slide, please. So the next loop of my roller coaster would be the bowel surgery, and I think that was a step for me since the onset of this that scared me the most. I had parked it in a cupboard and I'd locked the cupboard door. But I knew that my bowel surgery would require me to have a permanent stoma, and it terrified me, and it had taken me months to prepare myself mentally for that stage. And I did feel ready at this stage because I've been inspired by meeting people who live perfectly normal lives with a stoma, and I knew that I could achieve that. And I had the motivation that I needed to go on to that stage. And the plan was that 6 weeks post my liver surgery, I would be back in hospital to have bowel surgery. However, that was all thrown up in the air when I was told on my next scan that I'd shown a complete clinical response in my bowel. And that meant essentially there was no evidence of the tumour. I remember being in the house when they told me, and not knowing how to react to that, and them saying to me they couldn't guarantee it wasn't there. They'd have to do a flexible sigmoidoscopy to look at the tumour site. But from what they could tell, that was the case. And it turned out after the flexible sigmoidoscopy that, in fact, my bowel tumour had a complete clinical response to the chemotherapy. And I was given the choice of being able to still have the surgery to remove the site, because some people still feel that's the best thing for them, or the option to go on to a high surveillance scan system, basically. It's really hard to explain, but at the time of hearing that I'd had that complete clinical response, I find it really difficult to process that. It was incredibly positive, and I knew that I should feel incredibly grateful. But equally, after so long of having so much hanging over me, I still, and even now, only see the worst. And every time I go in for a scan at the moment, I still feel that cancer is going to be found again, and that they're going to find it again. So that was a really difficult time, because when I should be feeling happy and all of my family and friends would say, "Oh, brilliant, it's great." For me, that was never the case. And I've never quite got to that stage of being overjoyed with hearing that. Next slide, please. So it's been 6 months now since I got told I'd had a complete clinical response, and I've been through 2 phases of my high-level surveillance. So what that looks like is every 3 months I have an MRI scan, every 3 months I have a flexible sigmoidoscopy, and every 3 months I have a blood test just to see whether there are any signs with my blood that cancer is present. And then every 6 months I have a CT scan as well, which all means that by all being well, by 2033, I would have had 23 MRI scans, 11 CT scans, 18 flexible sigmoidoscopies, 4 colonoscopies, and 23 blood tests. If that's the case, then I'll be 52 years old. Both of my girls will be in high school. In fact, my biggest challenge will probably be the worry of an 18-year-old coming downstairs to go out with her friends and not passing the dad acceptance test of what she's wearing. Despite all that, I'm not going to lie, the mental struggles of the watch and wait scheme are really tough. And like I've already mentioned, every time I go in for one of those scans, and every time I come out of one, I have to wait a few weeks to get the results, I fully expect to be told that they find other signs of cancer. And no matter how much anyone tells me to be positive, I can't shake that thought and I can't shake that feeling, because that's just how it is. When I was first diagnosed with having cancer, I decided that I was going to run the London Marathon. I was inspired by Adele Roberts, who had just run one with a stoma. And I decided that that's what I would do, because for me, it would prove to me that even though I had a stoma, because at that stage I thought I would have one, I could still be who I was and I could still do the things that I've always done. So I signed up to run the London Marathon for Bowel Cancer UK. And my wife, who is not a runner at all, she's never even run a half marathon and literally just run 1 10K. She also decided that if I could go through what I'd been through up to that stage, she would run the marathon for Bowel Cancer UK as well. So we both signed up and set ourselves the target to raise £7,500 for Bowel Cancer UK. And I'm determined to give back, and I'm determined to do my bit to raise money for a fantastic charity that do fantastic work. But for me, it's also the awareness that brings when we talk about young people that have bowel cancer, because it is traditionally, like Malcolm said, something we associate with older people. And I read a report in The Guardian, which I think was the one Malcolm was alluding to, that said bowel cancer deaths would increase by 1/3 in under 50s in the next year compared to that from 2014 to 2019. So it is still there, and it's really reassuring to hear all those fantastic things that are happening in terms of treatments and in terms of surgeries. And I just hope that the money that we're raising will really kind of support those and support other families like like the ones that I'm going through. Next slide, please. I just wanted really to finish by summarising 4 things, I guess, that I've learned on this horrible part of my life. Cancer's changed me as a person, and that seems a really common theme to others that I talk to who have cancer. I'm not the person that I was before. It's completely broke me down and taken away huge levels of my confidence, but equally it's taken away huge levels of me as a person, and I resent it for that. Equally, that's not me being completely negative. I'm incredibly lucky to be where I am, and I'm privileged to have that chance to hopefully look forward for another 1, 10, 50 years of my life. Managing other people is really difficult when you have cancer. People always want to know how you feel. People feel sorry for you. They look at you differently. They treat you differently. And that's really tough because it's hard enough managing yourself without having to manage other people's emotions. And I find that incredibly difficult to deal with. And you find yourself being a person you're not around them to keep them happy, and then just getting home and feeling really exhausted. So sometimes that is really tough. You're allowed to have bad days, and you know what? I think this is life in a whole. I took a while to really understand this. We're all going to get bad moments in our lives. We're going to have days where we feel awful. And for me, I would get those quite regularly. And I learned that in those situations, sometimes it's okay just to literally sit on a sofa with a pair of joggers on and binge watch something on telly or go to bed early, because the next day the sun's going to rise, it'll be a new day, and hopefully you'll have a more positive outlook. And finally, it's what I alluded to at the start. We're all riding our own roller coaster. We shouldn't compare our roller coaster to somebody else's. And for me, it was always tough when the first thing people would say to you when you would tell them you had cancer was that their friend had cancer or a loved one had cancer and they survived, so it'll be fine. Because actually, this is my story, this is my cancer, and I still don't know what that's going to look like in 5 years' time or in 10 years' time. Next slide, please. So I just wanted to finish really by saying thank you. This is the first time I've kind of shared my story in this way, so thank you for the opportunity. I've just included a few links there. So I did write a blog 12 weeks after my surgery. So if anyone's interested, you can go and take a read. I think I'm better at writing than I am at talking. And also just a link to my Just Giving page. So if anyone does feel they'd like to make a donation to Bowel Cancer UK, please do visit it and make a donation. It really is a fantastic cause. And thank you all for listening.
Thank you so much, Richard, for sharing your personal experience with us today. We will circulate to everybody who's attended today Richard's Just Giving link and the blog link in case anyone is interested in taking a look or supporting his efforts in preparation for the marathon. Our next speaker today is Sarah Weston. Sarah is Head of Services and Support for Bowel Cancer UK, managing a portfolio of services, delivering a range of specialised support to patients and their loved ones, and working with teams focusing on engaging with healthcare professionals. Sarah's worked in cancer care and mental health support in the charity health and social care sector for over 20 years. Sarah's expertise include patient support services and driving for earlier diagnosis of cancer through work on awareness of symptoms, supporting, screening and understanding of barriers to diagnosis. Welcome, Sarah.
Hi, thanks Rebecca, and thanks for organising this great session. Tough to follow on from such a powerful session, but hopefully as Richard kind of talked about, it's a really different roller coaster for each person, and people will be at all different kind of points of that journey. And I hope as we kind of talk through today some of the services and support that we have on offer at Bowel Cancer UK, people will have a sense of the types of things that are on offer to support people. So just in case people aren't aware, Bowel Cancer UK are the leading specialist bowel cancer charity, and our mission is that we're determined to save lives and improve the quality of life of everyone affected by bowel cancer. So we've that's our kind of aim as an organisation, and we work in a number of areas to achieve this. So through our services, which we'll touch on today, but also kind of campaigning, research and education as well. So we're going to focus more on the service side of things today, but I will touch on some of the other bits that Bowel Cancer UK do as well. So I'm going to say next slide, please. So the first service I wanted to just touch upon is our Ask the Nurse service. So our Ask the Nurse service is currently an email-based service. Anyone can contact with a question, and it's staffed by a group of specialist colorectal nurses who between them have a range of specialisms within bowel cancer, and also have many years between them in caring for and supporting bowel cancer patients and their loved ones. We get all sorts of questions that come through this service. So from pre-diagnosis questions, so people might be worried about things that they've spotted or about symptoms. They might be asking about screening, but right the way through the pathway. So we get some complex questions about genetics, potentially about things like clinical trials or treatment decisions, etc. And this team are really well placed to be able to come back with really comprehensive answers to people's questions. And they will also provide follow-up answers as well. So if there are more questions that come off the back of their response, then they will come back to people as well. So a really fantastic service that will support with any questions that people have. We would hope that people are getting kind of lots of answers from their clinical teams, etc. But we all know that sometimes we go home and have an additional question, and a great place to be able to ask some of those questions. I'm going to say next slide, please. So our health information is accessed by literally hundreds of thousands of people each year, and is highly rated by patients and clinicians. So all of our information is evidence-based, it's peer-reviewed, and so we know that it's quality assured. And as it says on the slide, it covers a wide range of topics. So again, right through that cancer pathway, so thinking about symptoms, risk factors and screening, but also for people at diagnosis and thinking about the different treatment options and living with and beyond bowel cancer, knowing that there's more than just the clinical things that are going on. So we're really reassured that we can always share high quality information with patients through our health information. Next slide, please. And so just following on, we have a whole range of publications, and on the slide there are a few examples there specifically for people going through treatment. And all of our publications are available on our website, and they're all free to download. We did a review of our publications recently just to understand which were the most popular booklets and which were the ones that we really needed to make sure were in the hands of patients. And those are the ones that we've been able to print, so they are able to be accessed in print as well as in download. If you were a healthcare professional, you could order in a large set of those so that you could distribute them to your patients. If you were a patient or general public and interested, you could actually access that and just order individual ones as well. So through our website, you can access all of those things. In terms of, as I said, we peer review, we lay review all of our health information. And we're keen to kind of get feedback and more information from people using it as well. So if ever you have any queries or any feedback, I think this PowerPoint will be shared afterwards. And if you want to get in touch, there is the contact details for our health information team on there as well. Next slide, please. So what we've talked about thus far is mainly around our kind of clinically led services, where we have lots of clinical input into those services. But we also have a range of peer support services as well. We had a lot of feedback that people wanted to be in touch with, or certainly valued the experience of people that have been on a similar journey or had had kind of similar experiences, etc. And so the first of our peer support services that I wanted to just chat through today was our online communities. So if you were to look on our website, the very top toggle on the website would take you through to our online forum. You don't have to sign up to our forum to access it, so you can go and have a look around and have a read if that is useful and helpful to you, but it will just mean you can view the conversations, not join in if you don't sign up. Again, if you were to look on our online forum, it covers right across the kind of pathway. So there are sections for people that are worried about cancer, who might be in the stage that they're talking to their GP, or might not even have spoken to their GP yet, and kind of want to be kind of connecting with people about how they kind of move things forward, right through the kind of diagnosis pathway. So there are areas that should be useful to lots of different people to be able to connect with people in a similar situation. We do have a number of bespoke groups on there as well. So things like, as Richard mentioned, so there is a space specifically for younger people, because there may be unique or kind of different needs in that space. We have a stage 4 group. We have areas for friends and family, and there is also an area for bereavement support. Now, all of those bespoke groups, it's just that we would need to, people would need to sign in to be able to access those. And part of the reason is just to make sure that we connect the right people together that are supporting each other from that perspective. What you can see on the screen there is that we also have some groups on Facebook. I would say some people, it's just around choosing the platform that kind of works for them. And obviously lots of people are already accessing Facebook. So we do have a range of groups on there as well. And they're all supported and facilitated by trained volunteers and staff, just making sure that they're safe and really welcoming spaces for people to be able to share their stories and speak to each other about their experiences. Next slide, please. We also trialled in 2023 some new online support groups. So where we have the online community, people can obviously be sending messages to each other, and those can be quite extensive or quite short, but obviously people are kind of typing those messages. And we wanted to try giving people the opportunity to speak to each other online as well. Currently, we have 2 different groups running. So we have a stage 4 group and a stoma group running online. They're run through Zoom, and as it says on the screen, they're a drop-in service, so there's no commitment to attending on a monthly basis. It is just about registering, and then if you're able and feeling up to and would find it useful to join, then when those sessions are on, you can join those sessions as well. Next slide, please. So apologies that this slide is a little bit sparse, and I think I'll explain why. But essentially, Bowel Cancer UK don't run any support groups themselves, other than the ones that we've just mentioned, the online support groups. However, we are aware there are lots of support groups out there, and that for some people, maybe that online space might not be where they want to be. It might be that they want to be connecting with people face to face and having those conversations nearer to home. What we have tried to do is to make sure that we can kind of connect people with those support groups. So we have been in touch with lots of support groups across the UK and have created a database. So if you were to click through on that link when the slides arrive, it will show you the areas where we know that there are support groups that are definitely running and definitely kind of keeping in touch with us, to make sure that people can attend those. So hopefully it gives people a bit of an option in terms of different ways that they might be able to reach out to others that might be experiencing similar things. Next slide, please. So we've talked a lot about some of the things that we've been doing directly for patients and their loved ones. However, a big part of our strategy that we launched last year is around earlier diagnosis. And a big part of that obviously is around awareness. So we really need to be thinking about talking to patients, the public healthcare professionals, and making sure that everyone is expert in kind of understanding the symptoms, understanding the screening process, and as Malcolm mentioned at the start, some of the risk factors as well. What you can see off to the right is the 5 main symptoms of bowel cancer, and that's one of our pieces of health information. It's currently, we're looking at our kind of messaging around that, but really key that at every opportunity we get the chance to share these so that people know what they're looking out for. So obviously the bleeding from your bottom and or in blood in your poo, a persistent and unexplained change in bowel habits, unexplained weight loss, extreme tiredness for no obvious reason, or a pain or lump in your tummy. So kind of 5 key messages that we really want to kind of get across, that people are aware of that there's something to think about and aware of something that they might need to go and get checked out. As part of the awareness programme, we have an awareness talks programme, and that is a volunteer-led programme delivered by trained volunteers. A lot of them have a bowel cancer experience themselves, so it may be themselves or it may be one of a loved one for them. And they will be talking to people about risk factors, they'll be talking about screening, and they'll be talking about those signs and symptoms as well. So really kind of getting those messages out into the community. And we tend to do those in kind of workplaces and community groups. So if anyone on the session would be interested in having one of those, then you'll be able to get in touch through the slides as well. Next slide, please. So an exciting new part of our awareness programme is our awareness roadshows. We received some funding last year, which means we are able to deliver these roadshows for the next 3 years. And we have already piloted them going out to Liverpool, Belfast and Cardiff last year. And we have a range of locations that we're going to this year all across the UK. What you can see in the pictures may not be immediately obvious that it's an inflatable bowel, and so we take that out into the community so that it's quite eye-catching. It's quite a conversation starter. I think it's safe to say that you can walk through the bowel in the middle of your high street, etc. And it, as I say, it really kind of catches the eye and gets people kind of talking about some of those messages. It's really good in terms of that you can talk as you walk through it, you see different areas about bowel health, but it does also show the progression of kind of bowel cancer, the disease itself, and it makes it very visual in terms of why it's so important that we catch it early and why it's more treatable at those kind of earlier stages. I am off the back of Malcolm's presentation at the start. I think I'm going to be referring to this team as the Max Verstappen team now, that they're trying to get people moving quickly. So as you can see, there's a few different activities that we're really trying to get people aware and kind of talking about bowel cancer from that point of view. Next slide, please. So another piece, and I'm conscious we've got different people in the audience today, is about our health professional education and engagement, and this sits under our services too. So we work with both health professionals in primary care and secondary care. In primary care, thinking very much about that earlier diagnosis piece and making sure that people, wherever possible, are kind of up to date with those updates, as Malcolm was talking about at the start, making sure that people are kind of engaged with some of those messages and updates and kind of research and policy, etc. as well. In secondary care, it's obviously about improving outcomes, improving the journey for cancer patients, and just making sure that we're really engaging healthcare professionals with updates that we have, but also anything that they might be needing from a kind of educational point of view. So it talks about on the slide that we actively support the National Colorectal Cancer Nurses Network, a network I'm convinced is designed to trip us all up in these moments, as it has quite a few Cs and Ns. But membership of that is free, and there's a lot of benefits to joining. We also have the professionals network as well to support healthcare professionals. In terms of, it talks in the slide about that we run regular education events and engagement events, etc. So to give you an idea about what some of those are, we have had healthcare professional events looking at things like genomics, colorectal cancer in younger people, which I know has come up today, FIT. We have a module on FIT, thinking about earlier diagnosis, management of anemia, and things like pelvic exenteration. So areas where we were getting feedback from healthcare professionals that they really wanted to have some kind of specialist support or training. We were able to put sessions on, and if you are a healthcare professional on the call, then you can join our network and we'll be able to access all of those off the back of this. Next slide, please. So just back to the patients again, the patient support events. So we've had a range of events, some in person, quite a lot online over the last couple of years, kind of post-pandemic. And these sessions, we had gone out to the bowel cancer community and asked the things that they wanted additional support or information. And we've run a whole range of sessions. So in areas, and the couple of examples on the screen are things like diet or prehabilitation for surgery, etc. There's a whole range of them that sit, you can access them through our website or through YouTube. So if you were to look on our website, you'd see any upcoming ones, but also any that have been delivered in the last couple of years would be there for you to be able to access. So if there was anything useful from a patient point of view, they're a fantastic way to get up to date with information. At the end, there's often a Q&A session as well, so the opportunity for people to be able to ask questions of the specialists, and hopefully there might be some relevant questions given they're not live now. Next slide, please. And then our family, friends and carers hub. So I think, as Richard mentioned, it's not just the patient going through the experience and the journey. And we actually worked with some family, friends and carers to co-produce this hub. We asked them what it was that they thought would be useful. And they were very clear that they felt a kind of place where all of the information was in one place that they could access, that really focused on their needs in supporting someone. So we do have the Friends, Family and Carers Hub on our website. Lots of it is our information, but wherever we might not be the specialist, we've signposted to the relevant places just to make sure that people really get the support that they need from us and from other organisations as well. Next slide, please. And then just finally, I just wanted to mention that obviously, as I mentioned at the start, Bowel Cancer UK isn't just about services. We also fund research, and our research in particular is looking at earlier diagnosis and better treatments. And so there is an area of the organisation that's working on delivering from a research perspective. We also have a policy and influencing team. So again, they would be looking at how they can improve cancer outcomes and cancer journeys through engaging with the various governments and various national statutory bodies, etc. And so all of that activity is also happening at Bowel Cancer UK, but we're not going to touch on so much today. And as I briefly alluded to, so we have a new strategy which we launched last year on a mission, and it is particularly focused on earlier diagnosis. We know that if we can move more diagnoses from stage 3 and stage 4 to stage 1 and stage 2, that not only will more people survive, but more people will have a better quality of life as well. So we're really keen through all of the services that we've talked about today, that we and those areas that are on the slide too, that we move things forward in that space. And you might have seen things like our Get On a Roll campaign, so trying to get those symptoms on things like toilet roll and really trying to just get those symptoms out there, get people thinking and talking about bowel cancer and bowel health and much more. So I think that's me finished for today. Thank you so much for your time, and I'm going to hand back to Rebecca.
Thanks, Sarah. It's really great to hear about all of the amazing work that Bowel Cancer UK have been doing. We have got time for a couple of questions, and we've had a couple come in via the Q&A. Malcolm, I think both of these will be for you. So the first question is, when a patient has a single lesion liver metastases at diagnosis, how does this factor into treatment planning of ensuring as quick bowel resection as possible, but with advanced disease?
Yeah, thanks very much. I mean, I think the key to this is what we call the MDT, or multidisciplinary teams meeting. And MDTs are now commonplace. I go to 3 a week, where we discuss patients, and in the room there is a whole spread of expertise present, ranging from not just the surgeons, but medical, clinical oncologists, radiologists, and of course, probably one of the most important groups of all, the clinical nurse specialists, who often will administer the organisation of all of this. Certainly with the situation where you have a patient who has got what we term systemic disease, in other words, the disease has left the bowel and gone somewhere else, there are a variety of options that are available. One of them might be to remove both the lesion in the liver and the bowel cancer itself at the same sitting. I've got a patient that we're doing precisely that with in about 10 days' time. Of course, what that requires is that you've got to be sure you're going to get it all out. You've got to make sure the right people are in the operating theatre. And so we're very lucky that we have multi-specialty teams that can come in and do that. But it may be that actually that patient's tumour profile, as I was discussing at the end of my talk, is indicative of the fact that they would actually respond very well to a form of therapy that doesn't include surgery. And again, we've seen some really dramatic responses, in particular to immunotherapy, whereby they may not be able to completely avoid surgery, but as in Richard's case, you might well get an absolutely superb result from treatment of the primary cancer, and then that leaves the door open to deal with the other areas more effectively. So it's kind of very individualized is the honest answer, and it's one that's only made after extremely careful consideration.
Thank you. And actually, following on from that, we've had another question, and this one about radiotherapy.
Yeah.
So how often is radiotherapy on the bowel given pre-surgery in a stage 4 patient, and what treatment benefit does it add?
So radiotherapy in bowel cancer is in the initial treatment of the bowel cancer is reserved for patients who have rectal cancer. So it's the tumours that sit within 15 centimetres of their tail end. And we've been using radiotherapy now for years. And certainly there is often huge benefit to using a combination of radiation and drugs to firstly and primarily shrink down the tumour to render it operable, whereas before it might have been inoperable, or to reduce the risk of it coming back. Now, in the stage 4 patient, that's a little bit more different, because at stage 4, essentially what that means is you've already established disease outside the area of where the primary growth is. So radiotherapy can be used in conjunction with other treatments, but often in the situation where you have widespread disease, you would go for a systemic treatment which treated the whole patient rather than just a very isolated area. But it certainly plays into it. And again, the type of radiotherapy that is used nowadays is so much more focused and is so much more carefully controlled. I also, in my hospital, we're one of 2 units that has a proton therapy unit, where you're using a different kind of radiation to what is traditionally used. Now, currently, we're not using that for rectal cancers, but one can see with the further research that's now going into the 2 national centres, that may also become a further treatment that becomes available that isn't currently being used. You're muted, Don. You're muted. You're muted.
Thank you, Malcolm. And we've come to the end of our time today. So it just leaves me to say thank you so much for joining us for today's webinar, and thank you for our speakers as well. I hope you found this session interesting. Please look out for the details of our next webinar in the series, which will be shared shortly. Hope everyone has a great day.